All right, now the competencies, the standard competencies for this chapter: airway management, respiration, and artificial ventilation. These will be the core contents of this particular chapter. It applies knowledge of general anatomy and physiology, patient assessment, and management in order to assure a patent airway, adequate mechanical ventilation, and respiration for patients of all age groups or all ages. When we focus specifically on airway management, we'll look at the anatomy, we'll look at how to assess the upper and lower airway, and we will review techniques, or we will learn techniques that are necessary to keep the airway open. With respiration, we will review the anatomy of the respiratory system. We look at the physiology and the pathophysiology of respiration. So there must be an understanding of the function and abnormal function, and that will cover pulmonary ventilation, oxygenation, and respiration. We will look at the assessment and management of adequate and inadequate ventilation, which is a very important assessment skill for pre-hospital providers. The ability to determine if your patient has poor ventilation or good ventilation is very important. We will also look at the administration of supplemental oxygen therapy. For the artificial ventilation aspect of the chapter, we'll look at assessment and management of adequate and inadequate ventilation. We'll look at artificial ventilation, minute ventilation, alveolar ventilation, the effect of artificial ventilation on the cardiac output, because these two systems, the respiratory and cardiovascular system, are very closely linked. For the pathophysiology, it applies fundamental knowledge of the pathophysiology of respiration and perfusion to patient assessment and management. So we need to have a understanding of what is going to happen when the respiratory system is not working effectively, and how and how that will affect perfusion. Introduction. The primary component of caring for patients is ensuring that they can breathe adequately. So airway management is one of the most important skills that a EMT must learn and master. If a patient doesn't have an airway, if a critical patient doesn't have an airway, nothing else matters. When the ability to breathe is disrupted, oxygen delivery to tissues and cells will be compromised. Oxygen reaches body tissues and cells through breathing and circulation. We need to review the anatomy of the upper and lower airway. So you need to be familiar with the structures that are found in the upper airway and structures of the lower airway. The respiratory system consists of all the structures that make up the airway and help us to breathe or ventilate. The airway is divided into the upper and lower airways. The upper airway consists of the nose, mouth, oral cavity, and pharynx, which is the posterior portion of the throat, larynx, which is an important landmark that differentiate where the upper airway structures end and the lower airway structures begin. And the larynx is where the glottic opening is going to be found, which leads to the trachea. The upper airway's main function is to warm, filter, and humidify air as it enters the body. Pharynx. The pharynx is a muscular tube extending from the nose and mouth to the level of the esophagus and the trachea. The esophagus goes to the stomach, and it is in a posterior portion if you compare it to the position of the trachea. So the trachea is anterior and it goes to the lungs. The esophagus is posterior and it goes to the stomach. The pharynx is composed from top to bottom of the nasopharynx, which is the posterior portion of the nose, the oropharynx, which is the posterior portion of the mouth, and the laryngopharynx. This is a posterior portion of the area where you have the glottic opening or vocal cords. Now, looking specifically at the nasopharynx, it filters out dust and small particles. It warms and humidifies air as it enters the body. And this function is better with the nasopharynx than the oropharynx. The oropharynx, this is a posterior portion of the oral cavity. The epiglottis, which is a cartilaginous leaf-shaped structure, is superior to the larynx, and the purpose of the epiglottis is to prevent anything that is not air from entering the trachea. The larynx is a complex structure formed by many independent cartilaginous structures. It marks where the upper airway ends and the lower airway begins. And this diagram, where's my pointer? This diagram over here shows where you would find the thyroid cartilage. The superior portion of the thyroid cartilage is referred to as the laryngeal prominence or the Adam's apple. Just below the thyroid cartilage, there's a membrane that's called the cricothyroid membrane. It is a landmark for surgical procedures if the upper airway is significantly compromised. Just below that, just below the membrane, is the cricoid cartilage, which is the first cartilage of the trachea that forms a complete ring. So the larynx, thyroid cartilage forms a V shape anteriorly, so posteriorly the thyroid cartilage is open. The cricoid cartilage is the first ring of the trachea. The glottis is the area between the vocal cords. Now let's look at a review of the anatomy of the lower airway. The lower airway's function is to deliver oxygen to the alveoli. Lower airway includes the trachea, bronchi, lungs. Trachea. The trachea is a conduit for air entry into the lungs. It divides at the carina. That's where it bifurcates into two main stem bronchi, right and left. The bronchi are supported by cartilage. The bronchi distribute oxygen to the lungs. And eventually the bronchi will break down into bronchioles, and at the end of the bronchioles there are alveoli air sacs. So the bronchi becomes bronchioles or break down into bronchioles and are made of smooth muscle. Smaller bronchioles connect to alveoli. Oxygen is transported back to the heart and distributed to the rest of the body. So when the oxygen gets down to the level of the alveoli, it diffuses into the pulmonary capillaries, which are coming from the right side, the deoxygenated side, and then it is transferred via the pulmonary veins to the left side of the heart. The heart and great vessels, vena cava and aorta, are found in the thoracic cavity, specifically in the space known as the mediastinum. So the mediastinum contains the heart, the great vessels, the esophagus, which is posterior, the trachea, which is anterior, the major bronchi, and many nerves. Now let's look at the physiology of breathing. And what is important to understanding the physiology of breathing is being able to differentiate the process of ventilation, oxygenation, and respiration. So the respiratory and the cardiovascular system work together to ensure a constant supply of oxygen and nutrients is delivered to cells, and to also remove carbon dioxide and waste products from the body. The physiology of breathing will focus on the process of ventilation, oxygenation, and respiration. Ventilation is the physical act of moving air into and out of the lungs. And when we obtain a breathing rate for a patient, we're actually checking a ventilation rate. So you can't really check a respiration rate. You can check a ventilation rate. Because when we talk about respiration, it's really gas exchange. And if we are going to check gas exchange, then you're starting to look at perfusion. You have to look at perfusion to determine if gas exchange is occurring. So ventilation is a physical act of moving air into and out of the lungs. Oxygenation is the process of loading oxygen molecules onto hemoglobin molecules in the bloodstream. And 4 oxygen molecules are required for the red blood cell to be properly oxygenated. It cannot hold more than 4. Respiration is the actual exchange of oxygen and carbon dioxide in the alveoli as well as the tissue of the body. So we check a ventilation rate by counting the rise and fall for 30 seconds. We multiply that by 2. Patient should not be talking to you at that time. If it is abnormal, you check it for a full minute. To determine if your patient is properly oxygenated, you need to look at the patient's presentation, and you need to consider your pulse ox values. So pulse oximetry measures oxygenation. Excuse me for a sec. So the pulse ox measures oxygenation. For respiration, this is where your stethoscope is now important. So your stethoscope is what you're going to use to determine if respiration is compromised. If you hear fluid in the lungs, if you hear hoarse crackles, fine crackles, things that can interfere with the exchange of oxygen. So the stethoscope is for respiration, your pulse ox is for oxygenation, and you count your ventilation rate. Now, let's look at each individually. Ventilation. Ventilation is the act of moving air into and out of the lungs. So it's a mechanical action of breathing. It involves inhalation and exhalation. During the inhalation phase, this is active, so muscles are being used during this stage, which means contraction will occur. So inhalation is active, it's a muscular part of breathing. The diaphragm and intercostal muscles contract, this generates a negative pressure in the thorax, allowing air to enter. So when the diaphragm and the intercostal muscles contract, it causes the thoracic cavity to increase in size, and that increase in size causes a negative pressure inside of the thoracic cavity, or negative intrathoracic pressure. And this will now cause air to be pulled into that space to fill it. The lungs require the movement of the chest and supporting structures to expand. Partial pressure, this is the amount of gas in the air or dissolved in fluid blood, which must be equal. Oxygen and carbon dioxide both diffuse until partial pressure in the air and the blood are equal. Inspiration delivers oxygen to the alveoli, and in order for that to occur, there must be good tidal volume, and we need to consider dead space. So tidal volume is the amount of air that is taken into the lungs when we breathe in and out, specifically when we breathe in. And you measure that by observing your patient's chest rise. So if your patient has adequate chest rise, that's a representation of tidal volume. Dead space is anywhere within the respiratory tract where the exchange of oxygen and carbon dioxide cannot occur. So in order to get air all the way down to the alveoli, there must be adequate chest rise. If the chest rise become compromised, then the air will stop in the dead space, and that's anywhere outside of the alveoli. The air is going to stop in the dead space, and the dead space will begin to increase. And this is why when we have a patient who is not communicating with us and their chest rise is compromised, we have to breathe for them, because we don't want the dead space to expand. If it expands, it means less air is reaching the alveoli for the process of respiration. Now, exhalation is the other phase of ventilation. Does not normally require muscular effort. So, excuse me, it's normally exhalation, no muscle is required. It's a passive phase. This is where the muscles start to relax, the diaphragm and intercostal muscles. However, if there is an issue with the air passage, if it's too narrow, or if it's inflamed, or if it's swelling, then the patient is going to have difficulty exhaling. And this is where you will start to see them using muscles to exhale. So if a patient is using muscles, you can see muscles being used when the patient is exhaling, they're not in good shape. So exhalation does not normally require muscular effort. It's a passive process. The diaphragm and intercostal muscles relax. When this occurs, the size of the thoracic cavity decreases and the pressure inside the thoracic cavity increases. So there is a rise in the intrapulmonary or intrathoracic pressure, and this will push air out of the lungs. So the smaller thorax compresses air into the lungs. So we breathe in naturally with negative pressure, and we exhale naturally with positive pressure. Regulation of ventilation involves a complex series of receptors and feedback loops. Failure to meet the body's need for oxygen may result in hypoxia. and this is based on pH changes in the blood and the cerebrospinal fluid. So the primary stimulus to breathe is based on changes in the pH, and the receptors for the primary stimulus are located in the brain stem. And what the brain stem receptors are responding to, chemoreceptors we're talking about now, chemical receptors. What they're responding to is there is a rise of or an increase of CO2 in the blood, and that CO2 is combining with water to form a weak acid, carbonic acid, which causes the pH to drop. When the pH drop, that's what the chemoreceptors is directly picking up. So it's not directly picking up the elevated levels of carbon dioxide. It's picking up the drop in the pH as a result of the elevated CO2 levels, and then the body will regulate based on that change. Signals are sent via nerves to regulate the breathing, to reduce the acidosis that's building up. So if the pH drop too low, that's going to be acidosis. If it rises too high, that's alkalosis, and the range is 7.35 to 7.45. So anything below 7.35 is considered to be acidic. Anything above 7.45 would be alkalotic. And neither is good. One is far worse though. Acidosis is terrible for the body. Now, hypoxic drive. The hypoxic drive is the backup for the primary stimulus to breathe. So if the primary stimulus to breathe is no longer present or it's not working effectively, the hypoxic drive will take over. And as the name suggests, the word hypoxia means low oxygen. That's what it means. The term means low oxygen. Because that's the term, that means that's the stimulus. So a person who relies on their hypoxic drive, their stimulus to breathe will be low oxygen levels in the blood. This is observed in persons with chronic respiratory illnesses, COPD, chronic asthma, persons who have lung infection and their lung tissue is damaged. A lot of the persons that are recovering from COVID, they're having these type of complications. So their drive is now the hypoxic drive. It's the hypoxic drive receptors are located in areas within the aorta and the carotid arteries, and they respond specifically to gas exchange. Sorry, they respond specifically to changes in the concentration of gas in the body, specifically low oxygen. Now, that's the process of ventilation. Let's look at oxygenation. Oxygenation is a process of loading oxygen molecules onto hemoglobin molecules in the bloodstream. It's required for internal respiration to take place. Ventilation without oxygenation can occur where oxygen levels have been depleted. Respiration is the actual exchange of oxygen. Respiration is the actual exchange of oxygen and carbon dioxide in the alveoli and tissues of the body. The cells take energy from nutrients through metabolism. So metabolism is how a cell creates energy, and in order for the cell to create energy to function effectively, oxygen must be involved. So once oxygen is involved, the cell is able to produce all the energy it needs to carry out its function, and that is referred to as aerobic metabolism. If the cell doesn't have the amount of oxygen required, then the energy production becomes low and the function of the cell is compromised. That is referred to as anaerobic metabolism. So there are two phases of respiration. You have pulmonary and cellular. So pulmonary is the exchange of oxygen and carbon dioxide in the lungs at the level of the alveoli and the pulmonary capillaries. Cellular respiration is the exchange of oxygen and carbon dioxide between the cells or tissues within the body and the capillaries. External respiration, pulmonary respiration, brings fresh air into the respiratory system, exchanges oxygen and carbon dioxide between the alveoli and the blood in the pulmonary capillaries. Internal respiration, exchange of oxygen and carbon dioxide between the systemic circulatory system and the cells. Now let's look at the pathophysiology of respiration. Factors in the nervous system that can affect, factors in the nervous system. The chemoreceptors monitor the level of oxygen. So you have receptors that monitor oxygen levels, carbon dioxide levels, hydrogen ions levels, and pH of the cerebrospinal fluid. And based on the changes that are picked up by these receptors, there are signals or messages that are sent back to the respiratory centers to make adjustments in breathing. Ventilation and perfusion ratio and mismatch. Air and blood flow must be directed to the same place at the same time. So when the patient breathes in and taking that oxygen and it reaches the alveoli, blood must be coming from the right side of the heart and end up into the pulmonary capillaries, and this blood must be deoxygenated. So the oxygen and in the alveoli and the blood must get to that area at the same time. If that does not occur, then no exchange of oxygen and carbon dioxide occurs and the blood returns to the heart deoxygenated, and that can ultimately affect perfusion. And perfusion is the exchange of oxygen and carbon dioxide, oxygen and nutrients, and the removal of carbon dioxide and waste from the body for the purpose of metabolism. So failure to match is the cause of most abnormalities of oxygen and carbon dioxide exchange. So when there's a mismatch, gas exchange does not take place. There's a lack of O2 in the bloodstream. CO2 is recirculated within the bloodstream, and that will lead to acidosis. And there is severe hypoxemia. So there is a significant drop in the amount of oxygen in the blood. Now, factors that can affect pulmonary ventilation, there can be intrinsic factors like infection, the patient has an infection, allergic reaction, unresponsiveness, which leads to tongue obstruction, and there can be extrinsic factors like trauma. Now, factors affecting respiration. Again, you can have external factors and you can have internal factors. External factors, atmospheric pressure can interfere with respiration. If the partial pressure of O2 is not balanced, that can interfere with respiration. Internal factors that can affect respiration, pneumonia, pulmonary edema, COPD, emphysema. Circulatory compromise, because both the respiratory and cardiovascular system are so closely linked in their function. If something is wrong with the circulatory system, it can also affect the respiratory system. So circulatory compromise. Trauma emergencies can obstruct blood flow to individual cells and tissue. Simple or tension pneumothorax that can cause respiratory problems. Open pneumothorax can cause respiratory problems. A hemothorax or a pneumothorax can cause respiratory issues. Other causes which are associated with the circulatory system: blood loss, anemia, hypovolemic shock, which is shock as a result of blood loss or plasma loss, and vasodilatory shock, which is a shock as a result of too much vasodilation distribution problem. So that's the review of the anatomy and physiology and the pathophysiology of the respiratory system. Let's look at the patient assessment now. Now, we need to keep in mind that once we're doing aerosol generating procedures, AGPs, which include CPR, nebulizer treatment, endotracheal intubation, continuous positive airway pressure, we need to ensure that we use proper PPEs. Do not do any of these procedures and your eyes, nose, and mouth is not protected. Remember that. Now, patient assessment. You must be able to recognize what is considered to be adequate breathing. In order to be able to do that, assessment must be done which has limited gaps or no gaps. So you need to be able to perform an assessment that doesn't have any gaps in it. If your assessment is thorough, then you'll be able to pick up where your patient's issue is, whether it's ventilation, oxygenation, or respiration. So recognizing adequate breathing. Adequate breathing should be between 12 to 20 breaths per minute for an adult, much faster for the pediatric population. Should be regular. So there should be a regular pattern of inhalation and exhalation. The patient should have bilateral, clear, and equal lung sounds. There should be regular, equal chest rise and fall, and there should be adequate depth, which is tidal volume. So you're checking the rate, the rhythm, the quality, and the depth. Anything outside of that will be considered abnormal. So recognizing abnormal breathing. This is a patient who is breathing too slow or too fast. This is a patient who is going to have an irregular pattern of breathing. This is a patient who will present with abnormal sounds or absent lung sounds. This is a patient who is going to be working hard to breathe. This is a patient who may have to be in a specific position to breathe. This is a patient in which their chest rise may be compromised, or which is a ventilation issue. Let me backtrack a bit. So Recognizing abnormal breathing, fewer than 12 breaths per minute, more than 20 breaths per minute, irregular rhythm, diminished, absent, or noisy, auscultated breath sounds, reduced flow of expired air at nose and mouth, unequal or inadequate chest expansion. Once we start to see unequal or inadequate chest rise, you should be thinking about a ventilation issue. Increased effort of breathing, shallow depth. If we're thinking about shallow depth, we need to be thinking about a ventilation problem. If a patient is breathing very slow, we need to be thinking about a ventilation problem. Skin that is pale, cyanotic, cool, or moist. Skin pulling in around the ribs or above the clavicles during inspiration. A patient may appear to be breathing after the heart has stopped. This is called agonal gasp. This is something you will observe in a patient who is in cardiac arrest. So this patient is usually pulseless. Agonal gasp is not considered normal breathing. And when observed, you need to just continue with your CPR. Now, Cheyne-Stokes or Cheney-Stokes respirations are often seen in patients with stroke or head injury. And this is an irregular breathing pattern, but it is regular. So it's irregular, but it is consistent. So it's a breathing pattern in which the breathing rate gradually increases, then it decreases, then it stops, then it gradually decreases, then it stops, gradually decreases, stop. So it's irregular, but it is consistent. And it is associated with stroke or head injury. Now, ataxic respiration. Ataxic respiration is going to be observed in a patient with a serious head injury. So usually this occurs in patients who have terrible head injuries. Now, the difference between ataxic respiration and Cheyne-Stokes is ataxic is irregular. It's a irregular breathing pattern, but it has no consistency. You cannot see any consistency to it. You can see a pause, then you see increase, pause again, slow down. There's no consistency to what you're seeing. That's ataxic respiration. So it's irregular. And you have your cosmal respirations, which are rapid, deep respirations, commonly seen in the diabetic patient, specifically the type 1 diabetic, the one that does not produce insulin. This type of breathing will present with an unusual questions at this time. No questions.
I'm not asking a question, sir. A while ago, it was muffled, so we didn't hear anything what you said.
Okay. Cosmal respiration. Cosmal respiration is associated with the diabetic patient. They specifically type 1 diabetic. And this is a patient that would be at risk for diabetic ketoacidosis. So the rapid breathing is a way for the body to compensate for that acidosis, and it produces an unusual odor on the breath. Patients with inadequate breathing need to be treated immediately. Now, assessment of respiration. Even though the patient may be ventilating appropriately, respiration may be compromised. The level of consciousness, skin color, and skin color are excellent indicators of respiration. Also consider oxygenation. Pulse oximetry is considered a routine vital sign, can be used as part of a patient assessment. Very important tool to incorporate in your assessment, especially for your medical patients. Not limited to medical patient, but you definitely need to use it for your medical patients if you're considering giving them oxygen. You want a baseline. So you want to know what the pulse ox is on room air before you start to give them oxygen. End-tidal CO2. This is a measurement of the maximal CO2 at the end of an exhaled breath. If the CO2 level is low, it is linked to hyperventilation, decreased CO2 return to the lungs, reduced CO2 production at the cellular level. If it's high, that is due to ventilatory inadequacy or apnea. What you need to take away from all this, if the CO2 level is low, your patient is breathing too fast. If the CO2 level is high, the patient is not breathing at all, or they're breathing too slow. Measured using capnometry. So you have colorimetric, end-tidal CO2, which is the color change. We're looking for a color change. Then you have capnometry. Capnometry only gives a digital value. And then you have capnography, which is the standard. Capnography is the standard. So even if you're using the other tools, eventually you have to switch over to capnography. Capnography gives a value and a waveform. Normal range is 35 to 45 millimeters of mercury. Can be used in spontaneously breathing patients with a special nasal cannula. Opening the airway. Emergency medical care begins with ensuring an open airway. Rapidly assess whether an unconscious patient has an open airway and is breathing adequately. So if the patient is not communicating to you, position the airway, ensure it's clear, look, listen, feel, simultaneously check for a pulse. If there is no breathing, evaluate the pulse for rate, rhythm, and strength. If there is signs of breathing, evaluate the breathing for rate, rhythm, quality, and depth, and manage accordingly. So position the patient correctly. Supine position is the most effective position to properly assess a patient's airway if they are not communicating. Unconscious patients should be moved as a unit. Most common airway obstruction is the tongue. Now, the methods to manually open the airway is your head tilt, chin lift, and your jaw thrust maneuver. These are the common methods for EMTs. The head tilt chin lift maneuver will open the airway in most patients for patients who have not sustained or are not suspected of having sustained trauma. Not going to go through the steps for the head tilt chin lift. This is something to focus on in your practicals. Jaw thrust maneuver. If you suspect a cervical spine injury, use this maneuver. Now, the purpose of the jaw thrust maneuver is to Manipulate the mandible to get the tongue out of the ear passage without causing any shifting of the patient's neck. You kneel above the patient's head, you place your fingers behind the angles of the lower jaw and move the jaw upward. Use your thumb to help position the jaw. Opening the mouth. Even if the airway is open, the mouth may be closed. You can use your cross finger technique. Place the tips of your index finger and thumb on the patient's teeth. Push your thumb on the lower teeth. Put index finger on the upper teeth. The index finger and the thumb cross over each other. This is a picture of your jaw thrust maneuver. Now, once we have positioned our way, we need to ensure that it's clear. And you may position the airway and there is fluid present. Fluid is present, then suctioning will be necessary. And there are 3 types of suction devices that can be available to you as an EMS responder. You have your handheld suction device, portable unit, and the fixed suction unit. Whichever suction device you're using, ensure that you're familiar with how that device works. A portable or fixed unit should have a wide bore, thick wall, non-kinking tubing, plastic rigid pharyngeal suction tips, non-rigid plastic catheters, a non-breakable disposable collection bottle, water supply for rinsing the tips. Inspect the equipment regularly to operate the suction unit. Check the unit for proper assembly of its parts. Test the suctioning unit to ensure vacuum pressure of more than 300 millimeters of mercury, not less than, but more than. Select and attach the appropriate suction catheter to the tubing. Now, once you make a decision to suction your patient's airway, it should never be done with the head in a neutral position once that can be avoided. So try and avoid suctioning with the head neutral. Never suction the mouth or nose for more than 15 seconds at one time for an adult, 10 seconds for children, 5 seconds for your infants. If the patient has an advanced airway, you do not exceed 10 seconds and it needs to be a sterile technique. Suctioning can result in hypoxia, can dry out the mucous membranes, and it can stimulate the vagus nerve, which can slow the patient's heart rate down. When patients have secretions or vomitus that cannot be suctioned easily, remove the catheter from the patient's mouth, log roll the patient to the side, clear the mouth carefully with a glove finger. If the patient produces frothy secretions as quickly as you can suction them, suction the airway for 15 seconds, less in infants and children, ventilate for 2 minutes, continue this alternating pattern until all secretions have been cleared. And that's suction. So you need to be familiar with your suction device, and based on the amount of secretions that is present, you choose the most appropriate suction catheter. There's a large amount of secretions, then you go in with a rigid type suction catheter or Yanker tip suction catheter. If there is minimal secretions, secretions coming out of the nose, or you have limited space in the mouth to maneuver, then you go with a flexible suction tip catheter or French type catheter. If you're gonna go into an advanced airway device to suction, flexible catheter is preferred. If you're gonna suction a stoma, flexible catheter is preferred. Now, basic airway adjuncts. Basic airway adjuncts prevent obstruction by the tongue and allow for passage of air and oxygen to the lungs. And you have your oropharyngeal airway and the nasopharyngeal airway. The indicators are important. Now, the purpose of the oropharyngeal airway is to keep the tongue from blocking the upper airway and make it easier to suction the oropharynx. Now, indication for your oropharyngeal airway. Again, indicators are very important, and this is where EMTs have issues. Because we're not looking for indicators and we're making decision to put in an airway adjunct. Look for indicators. Indicators must be present before the airway device is used. So for the oropharyngeal airway, the patient needs to be unresponsive, a gag reflex must be absent, and the patient must be showing signs of a ventilation problem. If these three indicators are not assessed for, then you shouldn't be using the device. Contraindication. If the patient is conscious, it's contraindicated. Any patient who has an intact gag reflex, it's also contraindicated for these patients. Now for the nasopharyngeal airway. So the oropharyngeal airway goes into the mouth, the nasopharyngeal airway adjunct goes into the nose. It is used in patients who is unresponsive or has an altered LOC, but there's an intact gag reflex present and is unable to maintain his or her own airway spontaneously. But there must be a ventilation problem present. So if a patient cannot maintain their airway effectively, it will affect their ventilation. If their ventilation is not affected, no airway adjunct is required. So if the ventilation is adequate, no airway adjunct is required. It must be compromised. So indications, patient must be semi-conscious or unconscious with an intact gag reflex, patients who will not tolerate an oropharyngeal airway, and as I stated previously, a ventilation issue must be present for you to use airway adjuncts. If it's not present, no airway adjunct is required. Contraindication. If the patient has severe head injury with blood in the nose or history of fractured nasal bone, it's not indicated. And most of the current protocols no longer use the NPA once it's a trauma patient. Now, the recovery position. The recovery position is used to maintain the airway in a patient who is semi-responsive or unresponsive, but they have adequate chest rise present and there is no signs of trauma. So that's the purpose of recovery position. So that's your airway adjunct. Let's go into supplemental oxygen administration. Always give oxygen to patients who are hypoxic. Some tissues and organs need a constant supply of oxygen to function normally. Never withhold oxygen from any patient who might benefit from it. But also, if it's not necessary, don't give it. So in order for you to be able to balance that, it means you need to do a proper assessment. So a proper assessment cannot be you look at the patient, oh, because he might breathe fast, he needs some oxygen. There's no context behind that. There needs to be a context. There needs to be description. I can't just look at a patient and say, okay, I'm going to give him some oxygen. Okay. He might be having breathing problems, but where exactly is the breathing problem? Is it a ventilation problem? Is it an oxygenation problem? Is it a respiration problem? So what are you treating? So proper assessment. Based on your assessment, if you think that hypoxia is present, give you oxygen. If you don't think oxygen is necessary, don't give it. It's a medication. So there needs to be indication for its administration. And just as though it has indication, it also has contraindications. So supplemental oxygen equipment includes oxygen cylinders containing compressed gas. Liquid oxygen is becoming more commonly used as an alternative, but to this day, oxygen cylinders is what most systems use worldwide. Gas. Now, safety consideration. Handle gas cylinders carefully. Make sure the correct pressure regulator is firmly attached before transport. A puncture hole in a tank can turn into a deadly missile. Secure cylinders when stored on the ambulance and when in use during transport. Now, the oxygen cylinders that are utilized in EMS utilize a pin indexing system for the regulators. And what the pin indexing system is basically, the cylinder has a series of pins on it and the regulator, pinholes on the cylinder, and the regulator has pins that matches with these holes. So it prevents the regulator cannot be attached to any other cylinder, can only be attached to an oxygen cylinder. So that's the purpose of the pin indexing system. So it prevents such mistakes as an oxygen regulator being accidentally connected to a carbon dioxide cylinder. Every cylinder of a specific gas type has a given pattern and a given number of pins. Now the pressure regulators. The cylinder when full is 2000 psi. We cannot give a patient 2000 psi if they require oxygen. So the purpose of your pressure regulators is to reduce that to a lower psi, 40 to 70, and then at that psi we can titrate it to a desired flow rate. So pressure regulators reduce the cylinder's pressure to a useful therapeutic range, usually 40 to 70 psi. Final attachment for delivering the gas is either a quick connect female fitting or a flow meter. And there are different types of flow meters. Flow meters usually permanently attached to pressure regulators on emergency medical equipment. It can be a pressure compensated flow meter, which you see that more in the hospital setting, or it can be a burden gauge flow meter. Now, hazards of supplemental oxygen. Oxygen supports combustion, so you need to be aware of that. Oxygen toxicity. Definitely need to be aware of that. So in other words, previously when we covered or reviewed the anatomy of the respiratory system, I mentioned to you that the red blood cells cannot facilitate more than 4 oxygen molecules. So once the red blood cell has 4 oxygen molecules, it's properly oxygenated. So if you give that patient more oxygen, there's nowhere for the oxygen molecule to go, and it now becomes a free radical, and it can damage cells that are already oxygenated. It can also wash off the nitrogen, can reduce the amount of nitrogen that is available in the body. And nitrogen is necessary for the body to make surfactant. Surfactant is important to the pliability of the alveoli. So it's what allows the alveoli to have that elasticity and promote the permeability within the alveoli so that oxygen can be exchanged. Too much oxygen can also cause vasoconstriction for a patient with a suspected MI. So it can lead to coronary vasoconstriction, which is not good for a patient that has a myocardial infarction. It can also lead to cerebral coronary constriction for a patient who has a stroke. So with these patients, if oxygen is not required, don't give it. So combustion. Oxygen does not burn or explode, but it does speed up the combustion process. Keep any sources of fire away. Make sure the area is adequately ventilated. Never leave an oxygen cylinder standing unattended. For oxygen toxicity, not all patients need high concentrations of oxygen. Oxygen can have detrimental effects in patients with certain illnesses, COPD, MI patient, stroke patient. When pulse oximetry is available, tailor oxygen therapy and administer the minimum amount necessary to maintain oxygen saturation at or above 94%. So whichever device you're using, start at the lower end, and if necessary, you gradually increase. Now, the oxygen delivery equipment, the commonly used oxygen delivery equipment in the pre-hospital setting is your non-rebreather mask, your bag mask device, or BVM as we call it, and your nasal cannulas. Your non-rebreather mask and your bag mask device are high-flow devices, and the nasal cannula is considered to be low flow. The valve mask or bag mask device is a positive pressure device, and the CPAP is also a positive pressure device, and if you're using a pocket mask, that's also a positive pressure device. So non-rebreathing mask, the preferred way to give oxygen in the pre-hospital setting. Patients who are breathing adequately but are suspected of having hypoxia. So if you suspect hypoxia is present, high flow. It's a combination of mask and reservoir bag system, and the reservoir bag must be fully inflated before putting the device on the patient. Make sure the reservoir bag is full before placing the mask on the patient. Adjust the flow rate so the bag does not collapse when the patient inhales. When oxygen therapy is disconnected, remove the mask. Now, don't turn off oxygen with the mask on the patient. Take the mask off first, then turn off the oxygen. Now, for nasal cannulas, which is your low flow device, deliver oxygen through 2 small tube-like prongs that fit into the nostrils. Can provide 24 to 44% inspired oxygen when the flow meter is set at 1 to 6 liters per minute. So that's the range of a nasal cannula, 1 to 6 liters per minute. In the pre-hospital setting, if you're going to be using a nasal cannula as an EMT, don't go past 3 or 4 liters per minute. If you have to go above that, then the patient requires high flow. So the nasal cannula is used in patients with mild hypoxemia. A patient who breathes through the mouth or has a nasal obstruction will not benefit. When you anticipate a long transport time, consider using humidification. And you will consider the use of a humidifier if you suspect that the patient has airway burns or if the patient has a respiratory tract infection, because infections lead to dehydration. And if the mucous membranes are dry, then they don't absorb the oxygen gas very well. So you will consider humidification for these patients. However, in the pre-hospital setting, humidification is not done in the field unless there is a long distance between where you found the patient and where your unit is located. But usually, patient gets dry oxygen in the field. Once they get to the ambulance, then a humidifier is used because it's a device that needs to be kept in a sterile environment. Now, partial rebreathing mask. It's similar to a non-rebreather, so it's a high flow device. There is no one-way valve between the mask and the reservoir. The non-rebreather mask has a one-way valve, so the patient is only getting oxygen, right? With the partial rebreather, there is an opening that allows atmospheric air to mix with the gas that the patient is inhaling. So patients rebreathe a small amount of exhaled air. And the partial rebreathing mask can provide anywhere from, can be 6, 8, or 10 liters per minute. Anything above that, you would be wasting the oxygen flow. Now the Venturi mask, it's a mask based on its connectors that can give medium to high flow oxygen. Not common in the pre-hospital setting because the nasal cannula can pretty much do the same thing. So a number of settings can vary the percentage of oxygen while a constant flow is maintained. It delivers 24 to 40% oxygen. Now the tracheostomy mask. Patients with tracheostomies do not breathe through their mouth and nose. So the mask goes over the tracheostomy opening or tracheostomy tube. Tracheostomy masks cover the tracheostomy hole and have a strap that goes around the neck. It may not be available in an emergency setting. Improvise by using a face mask placed at the tracheostomy opening. Now, assisted and artificial ventilation. Basic airway and ventilation techniques are extremely effective. Follow standard precautions as needed when managing a patient's airway. Signs and symptoms of inadequate ventilation. So for you to determine if you're going to need to perform assisted or artificial ventilation, you need to assess the patient's mental status. You need to assess rate, rhythm, quality, and depth of breathing. And remember what I said yesterday. in the patient assessment lecture. Good chest rise or visible chest rise defines distress. Poor chest rise or no chest rise defines failure or arrest. A patient that you're going to breathe for, their level of consciousness must be compromised. Poor chest rise or no chest rise must be present. So that's what you're looking for. If poor chest rise is present and you're providing and you're using a BVM for that patient with whichever airway adjunct you think might be appropriate, then that would be considered assisted ventilation because there is still some amount of movement of the chest occurring, but it's not adequate. If the patient is not ventilating any at all, and you are using a BVM or a pocket mask on that patient, then it is referred to as artificial ventilation because the patient does not have any chest movement. You're creating the chest movement. So that's really the difference. But both require the use of BVM or pocket mask. So the signs and symptoms of inadequate ventilation: altered mental status, inadequate minute volume, excessive accessory muscle use, and fatigue. When assisting with a bag valve mask, now you will never ever attempt to bag a patient that is communicating to you. Never ever attempt to do that. So if a patient is still talking to you, don't put a BVM on them face and try back them. If the patient's level of consciousness declines or changes, think about which airway adjunct would be appropriate. And if you're going to bag that patient, then you need to ensure that the first 5 or 10 breaths that you give synchronize with the patient's breathing pattern. So you need to be squeezing the bag when the patient inhales and not when the patient exhales. And after 5 to 10 breaths, you should be able to take control of that patient's ventilation pattern. But if the patient is still communicating, do not try to bag the patient. Now, artificial ventilation. Once a patient is not breathing, begin artificial ventilation immediately via a mouth-to-mask technique or 1 or 2 person bag mask device. The most effective method is mouth-to-mask. That's the best way to do 1 person artificial ventilation. However, if you're comfortable with your BVM, you can also be very effective. 1 person BVM is not that effective in comparison to 2 person. So 2 person BVM or bag mask device is the preferred method. Now, normal ventilation versus positive pressure ventilation. In normal breathing, the diaphragm contracts and negative pressure is generated in the chest cavity. So we breathe in with negative pressure. When you are ventilating for a patient, you're actually forcing air into the patient's chest. So it's positive pressure. Because we're going against the normal physiology of breathing, it cannot be at the rate that that person would breathe. It has to be slow and it cannot be forceful, and the airway must be properly positioned. This will reduce the incidence of air getting into the stomach, leading to gastric distension and putting the patient at risk for aspiration. Now, with positive pressure ventilation, when we breathe for a patient, whether it's a BVM, a pocket mask, or we're using CPAP, This is referred to as positive pressure ventilation. When positive pressure ventilation is initiated for a patient, it causes an increase in intrathoracic pressure, which reduces blood pump by the heart. So if it's too forceful, you can also cut off the venous return or reduce the venous return to the heart. More volume is required to have the same effects as normal breathing. And if it's too forceful, we can force air into the stomach, putting the patient at risk for gastric distension. Now, mouth-to-mouth and mouth-to-mask ventilation. Mouth-to-mouth is done with a barrier device, and that's not something we practice in the pre-hospital setting. That's something we would consider for loved ones or family members. The mouth-to-mask ventilation is done in the pre-hospital setting, and it is something to keep in your back pocket. And when I say keep it in your back pocket, I don't mean literally put it in your back pocket. I mean, have that in your mind as a backup if your BVM technique is not efficient. Bag mask device provides less tidal volume than mouth-to-mask ventilation. An experienced EMT can provide adequate tidal volume if they have a good seal and the airway is properly positioned. Gastric distension. Gastric distension occurs when artificial ventilation fills the stomach with air. Most likely to occur when you ventilate the patient too forcefully or too rapidly. It may also occur when the airway is obstructed. So we want to avoid that. And to avoid that, ensure that you position the patient's airway correctly. Don't be too forceful. Ensure that you're going at the appropriate rate and pay attention to what you're doing. To prevent or alleviate distension, ensure the airway is appropriately positioned, ventilate at the appropriate rate, ventilate with the appropriate volume. If the stomach appears distended, recheck and reposition the head and perform rescue breathing. If there are still complications after that, then you may have to turn that patient on their side and put some pressure on the abdomen to push whatever is there up into the ear passage and then clear it. Now, passive ventilation. The passive ventilation is a method of ventilation that is now being practiced in the pre-hospital setting for patients in cardiac arrest. And it is becoming a favorable method for cardiac arrest for BLS providers because it reduces the risk of gastric distension. Now, what passive ventilation is, the patient is in cardiac arrest, an airway adjunct is placed in the patient's ear passage, and a high flow oxygen mask is placed on the patient. What is going to happen is when the chest compressions are created, there is a negative pressure from the recoil, and that recoil pulls the oxygen into the lungs. So the oxygen is flowing passively into the lungs, and that is mimicking the normal physiology of breathing. So it reduces the risk of gastric distension. So it's a favorable method for cardiac arrest. Now, automatic transport ventilators or resuscitators, not commonly used in the pre-hospital setting. You'll see these type of devices more commonly used in critical care transport. or critical care transport by ear, ear ambulance. So it's a manually triggered device attached to a control box. It allows variables and ventilations to be set. It allows the variables of ventilation to be set, lacks the sophisticated control of a hospital ventilator. It frees the EMT to perform other tasks. So it's a device you place on the patient, you put in some settings and you press a button and it gives the ventilation based on the settings. Now, continuous positive airway pressure. This is a non-invasive ventilatory support for respiratory distress, and this would be severe respiratory distress or patients who are at risk of going into severe respiratory distress. Many people are diagnosed with obstructive sleep apnea and they wear CPAP units at night. So this is where it was primarily used, because persons who have big neck or obese patients, when they sleep, the weight in the neck is causing the airway to lock up. So the CPAP creates a pressure to open the airway. So these persons are literally stop breathing in their sleep. However, research has shown that the same device can be beneficial to patients in the pre-hospital setting who have pulmonary edema, and it is widely used by EMTs now. So the mechanism, it increases pressure in the lungs, it opens collapsed alveoli, it pushes more oxygen across the alveolar membrane, and it forces interstitial fluid back into the pulmonary circulation. Therapy is delivered through a face mask held to the head with a strap-in system. Use caution with patients who have potentially low blood pressure, and I would say do not use it if the patient's blood pressure is low. It's positive pressure, so it can cut off venous return. Now, indications: the patient needs to be alert and able to follow commands. The patient must display obvious signs of moderate to severe respiratory distress. Respiratory distress occurs after a submersion incident. Patient is breathing rapidly. The patient has a pulse ox reading of less than 90%. These are all indicators to look for. Contraindication: if the patient is in respiratory arrest, contraindicated. If they're hyperventilating, can't use it. If they cannot speak, if they're unresponsive or cannot follow verbal commands, if they cannot protect their airway, if their blood pressure is too low, no CPAP. If there are signs of a pneumothorax or chest injury present, tracheostomy, active vomiting or gastrointestinal bleeding, facial trauma, cardiogenic shock, if they can't sit upright, they cannot tolerate the mask, these are things that would be contraindicated for the CPAP use. Now, the application is a resistance that creates back pressure that pushes open smaller airway structures as the patient exhales. 7.0 to 10 centimeter H2O is acceptable. It requires a flow rate of 15 to 25 liters per minute, can be higher. They are working on a device that can use a lower concentration of oxygen. Now, complications with CPAP. Some patients may find CPAP claustrophobic. It puts a patient at risk for a pneumothorax. It can lower the patient's blood pressure. If the patient shows signs of deterioration, remove your CPAP and begin positive pressure ventilation using a bag mask device. Now, special considerations: stomas and tracheostomy tubes. Patients who have had a laryngectomy have a permanent tracheal stoma, known as a tracheostomy. Neither the head tilt chin lift maneuver or jaw thrust is required for these patients. If the patient has a tracheostomy tube, ventilate through the tube with a bag mask device. If the patient has a stoma but no tube is in place, use an infant or child mask with your bag mask device to make a seal over the stoma. If you cannot ventilate with a stoma, try suctioning the stoma, which is very common. So stomas are commonly obstructed by mucus. Seal the stoma while giving mouth to mouth. If an obstruction, all right, so that's stomas. And also with your tracheostomies, if you're gonna suction, it needs to be sterile, right? So ensure that you have on a sterile glove when you're doing that procedure. No more than 10 seconds. For airway obstruction, if an airway obstruction completely blocks the airway, it is a true emergency. This can kill a patient. It will result in death if not treated immediately. In an adult, it usually occurs during a meal. In a child, it can occur while eating, playing with small toys, or crawling. The tongue is the most common airway obstruction in an unconscious patient. Causes of airway obstruction that do not involve foreign bodies include swelling from infection or acute allergic reaction or trauma, tissue damage from injuries. Mild airway obstruction. When a patient has mild airway obstruction, patients can still exchange air but will have respiratory distress. There is noisy breathing, wheezing, coughing. With good air exchange, do not interfere with the patient's effort to expel the object on his or her own. If the air exchange becomes compromised, then you treat it as an obstruction, a full obstruction. With poor air exchange, the patient may have increased difficulty breathing, stridor, and cyanosis. Treat immediately. For severe obstruction, patients cannot breathe, talk, or cough. Patient may use the universal distress sign, begin to turn cyanotic, and have extreme difficulty breathing. For severe airway obstruction, provide immediate treatment to the conscious patient. If not treated, the patient will become unconscious and die. If the patient is unresponsive, not breathing, and has no pulse, begin CPR with chest compressions. Every time you come to give your ventilation, check to see if something is visible in the airway passage. If you can reach it, remove it. Now, emergency cure for foreign body. Perform a head tilt chin lift maneuver to clear a tongue obstruction. Large obstruction should be swept forward out of the mouth with your gloved index finger. Abdominal thrusts are the most effective method of dislodging and forcing out an object. For dental appliances, they can cause an airway obstruction. Examples: crown, bridge, dentures, piece of braces. Manually remove the appliance before providing ventilation. Leave well-fitting dentures in place. Loose dentures interfere with the process and should be removed. With facial bleeding, airway problems can be particularly challenging in patients with serious facial bleeding. The blood supply to the face is very rich, so the blood vessels that supply the face is highly vascular. Injuries can result in severe tissue swelling and bleeding into the airway. Controlled bleeding with direct pressure and suction as needed or as necessary. And I believe that would bring us to the end of, one more slide left. Assisting with ALS airway procedures. So you may be required to assist an advanced practitioner with securing an advanced airway. And the procedures that must be performed to place an advanced airway include pre-oxygenation, which is the patient needs to be ventilated and oxygenated until their pulse ox is at 100%. You may assist in setting up the equipment, and in order to be able to do that, you have to be familiar with the type of equipment that an advanced or a paramedic could use. And then once the equipment is ready, then the procedure is performed. And when performing the procedure, remember, be magic. That's the mnemonic. Perform bag mask ventilations for pre-oxygenation. So we want to get the pulse ox at 100%. Evaluate for airway difficulties. So we need to be looking out for that. That's the advanced, not necessarily the EMT. Need to be looking out for issues that could make the procedure difficult. Manipulate the patient. So you have to manipulate the ear passage so that you can get visible. You can see the glottic opening easily. And then with the advanced one, to ensure that with the first attempt, the tube goes into the trachea. And if it doesn't, which it can, so they can miss, the advanced must have a backup. So attempt first pass intubation, and if that doesn't work, then the advanced should be thinking about a supraglottic airway device as a backup. Once the device is in, then placement needs to be confirmed. And we listen to the lungs, we look for mist in the tube, we look at the colorimetric changes, and eventually we will look at capnography, which is the gold standard for confirming advanced placement of an airway. That would be the end of this chapter.